We get this ready. I actually had a couple of people come to me and ask me the same question, and that was, what is a nurse practitioner, right? Or what is a physician assistant? Because we always speak about this, and I'll give you the answer. Although we have three nurse practitioners here with us, I can give you the answer. You're good there, sure, okay. So, nurse practitioners, so, as the name says, they are nurses. However, they decided to go a little bit further, right? They show a particular interest into, the more advanced cares of a patient. So they go into additional schools. So it's not like we take them out of the hospital ward and they come to work for us. They actually go to school 2 to 3 years, and they have to rotate with doctors. And they have to see a lot of patients, and it's not easy. It's like a compressed medical school, if we can say that, right? Yeah, there's a lot of training, and then they typically focus on one thing. So, for example, I have been working with Michael for about three years, maybe a little bit more, and Inman and Maria. And every day we work together, and in the morning we sit down and I discuss every patient with them. So we go over the list, what they're going to see that day. So, Mr. David, this is what we expect to see, yada, yada, yada. We discuss the medication, we discuss the challenges. I give them a little bit of a background, like, be careful because he has been falling down, so just make sure everything is fine. And then Dr. Benes actually does the same thing. And then at the end of the day, we sit down and tell me what happened. Right? And what happens is that why they are very important in what we do, right? The reason is that I told you earlier that there's about one person being diagnosed with Parkinson's every 6 seconds. So there's about more than 1.5 million to 2 million people with Parkinson's disease in the US. And how many movement disorder specialists are there? There's not even 800. So if you do the math, 1.5 million divided by 100, it's just too many people that we have to see. And like Dr. Benes said, it has to be a captain, and we have a team of people. So they're educated into these, and they spend a lot of time looking into this. Just like everything, some people more than others, right? And that happens with a doctor, that happens with a mechanic, So at least we try to make sure that the nurse practitioners working with us, they really understand what we're dealing with Parkinson's and similar things. So I just wanted to answer that because two people came with the same question.
Okay, all right. One of the first questions, they want your email address again. They said,
yes.
Have the nurse practitioner show her email address again.
Oh, that one was for the worksheets.
Okay.
Yeah, we can put them up.
Okay, all right.
Maybe we can put them up in our website as well, Eduardo.
Yeah, and we have an email that you can reach out to us, info, I-N-F-O, like information, info at neurology1.com.
Yeah.
And neurology1, O-N-E, not the number one.
And just to let you all know, they will have this presentation on video for you. And, Eduardo will make sure that you all can access it. And then they are also going to give me the link. So I will send it out to people that couldn't make it here today, or if any of you here have questions, I'll have it for you also. Okay. Let's start with, there were a couple questions on clinical trials. So what are some of the more promising trials that are out there?
So I'll tackle that one. Listen, there's a lot of stuff going on. And I personally believe that one of the studies that seems to be the most promising is, I mentioned a drug earlier, the CVN-424. That is the drug that works in a completely different way in people with Parkinson's disease. I'm just going to summarize that. All the treatment for Parkinson's, I mentioned you that there is a gas pedal and a brake pedal. People with Parkinson's, what really is happening is that the brake pedal is being pressed. That is the disease. So what we're doing when we treat a person is give enough medicine to overcome what the brake is doing. So we're pushing the gas pedal until the person finally gets going. What happens is that with time, we believe that so much gas, throwing so much gas, is what makes a person start developing some of these motor fluctuations and the dyskinesias, right? So our thinking is, what if instead of putting more gas in the fire, what if we release the brake? And maybe we're able to help people with less medicine, and if I have to use less medicine, then I can prevent or at least delay the progression to those advanced stages of Parkinson. So I do believe that is one of the most exciting studies going on right now, is the CBN 424. That's a study that, we have been testing it in people that have never been treated with Parkinson's, and now within the next month or two, we're going to begin testing it in people with already established Parkinson's disease to see how they respond. So that will be number one. The other one is the one that I mentioned, the Lenalidomide, the very difficult word to pronounce. That is a drug that is taken once per day. It's a completely different way to treat people with Parkinson's disease and seems to have some improvement. And I have looked into the data of this. I've been following these drugs for the last 2 to 3 years, and now they are moving to prime time, right? To the part where there is real research going on into this, and I hope that we can see these medicines in the market in the next 3 years.
Let me just add something. I agree with you, Dr. Rodriguez. I just want to add also, and keep in mind about the newer treatments that are going to be disease-modifying treatment for Parkinson's. Similar things we have for Alzheimer's, and we have been having those for a couple of years already. In Parkinson's, unfortunately, we don't have it yet. So those are the ones that really are going to target the underlying problem. And it's not just a treatment for the symptom, but to try to slow the progression of the condition. So keep that in mind as well for the disease modifying.
Actually, let me say one more. Write this down, people. There is I think it's working, yeah. There is a drug called prasinezumab, Prasine.
Spell it again.
Prasinezumab, PRA. This is a little bit, let's see. Hello?
Yeah.
No accent with this one. Okay, so P as in Paul, R, A, S as in Sally, I, NEMUZAB. So this is a drug that, we've been keeping an eye on it, right? And they're bringing a clinical study very soon. And what I like this medication is because you probably heard about the new medicines for Alzheimer's disease, that they go into the brain to try to remove the toxic protein from the brain. This drug is able to do it for people with Parkinson's disease. A little bit earlier, I mentioned you that we have these digital biomarkers. We need to find a way to measure the progression of Parkinson's disease other than looking at a person and saying, you look a little bit better, right? Because the FDA wants something very objective. So we're working on these things right now, and we really hope that we're going to have this stuff coming out within the next year or two.
Okay. So what's the first step for a clinical trial?
What is the first step for a clinical trial? So number one, everybody works a little bit different, but for the most part, it's the same. So we as doctors, we look at the data, and we make sure that everything that it is being done feels right, feels like there is hope for that particular drug. We look into the side effects, right? And obviously, we're talking about 200 or 300 people that might have tried that medicine, and we try to draw conclusions out of that, but the FDA says, no, we need to study this in a careful manner, right? So when a drug goes into a clinical trial, what happens is that we do have these committees. They are called IRBs, Institutional Review Boards. They will look into the medicines. And basically, as I say, they are the devil's advocate. What they're trying to do is make sure that the study does not go through. They're looking into everything bad. Just imagine a very negative person. That's what they try to do. They try to figure out everything that can go wrong. And the moment that they believe that the risk, the benefit might surpass the risk, and that it is worth it, and we're not hurting people, well, that is the point that the clinical trial is approved, and then we need people to participate, right? And I'm going to tell you something that 10 years ago, 70% of the drugs that were being tested for Parkinson's, Alzheimer's, and neurological disorders, they never came to fruition because people did not want to participate. So they have to close the studies, right? Nobody wants to be the guinea pig, right? That's what it is. But there's no other way around. So I always tell people, if you're going to participate in a clinical trial, you do it because you want science to be better, right? I want you to go into that. We always want our benefit. What's in it for me, right? But the truth is that it might not be us, it might be our children or our grandchildren, the one that will benefit from this.
Okay. Excuse me?
Oh, so the first step is, yes. So listen, if you are interested in clinical trials, you talk to your neurologist and you tell them, doctor, I would love to participate in a clinical study, or I would like to have more information. And we'll put you, typically we put you in a database that we have, an Excel spreadsheet, and we have some characteristics about that particular person. And, at least in our clinic, I can talk about my experience in our clinic, is that even if we don't have a study where you might be a candidate, we will find it for you. Okay, so, right now there are some studies looking into these substances that seems to protect the brain cells. We are not participating in those studies, but we're supporting the people because at the end of the day, we want science to improve. So we can get you in the right direction, okay? So always go to the doctor. Just don't stay with Google, right? And don't go to your Facebook Parkinson's disease support group. They're phenomenal. I love it. I'm part of them. Sometimes I answer some questions. Somebody puts a question, I answer it, and they say, I don't think you know what you're talking about. And then they say, talk to your movement disorder specialist, right? But the truth is that, you hear a lot of people making comments and all that. Listen, we're trying to give you the answers. Just tell your doctor and make sure that you're getting the information from the right source.
Okay. When it comes to diet, the neurologist says no caffeine, limit protein. What do you think? Anyone? Diet? Who wants to answer
So
the
diet
question?
is very important for all the for all conditions, but in particular for neurodegenerative condition. Diet can affect medication absorption. It can affect cause inflammation in the brain. It can worsen the condition itself. So diet is one of the key things that we need for brain health. And we should be talking about before even the condition, before even being diagnosed with any condition. We should all be very cautious about what we eat, about processed food, about the chemicals that are in the food as well. So exposure to certain types of food can actually cause, as I was saying, some harm to the brain, like promote inflammation. So yeah, Mediterranean type of diet is the one that has been recommended. However, this varies depending on the other medical problems that the patient has. And it's not only the diet, but also the water intake, for example, that is very important, that you should consider. And if in doubt, getting an evaluation with a nutritionist should be in your treatment plan as well.
Okay, and as far as the limiting the protein, they talk about, the protein with levodopa, carbidopa when you take your meds. So is that the person who wrote the question? Is that what your question
Okay,
is?
so protein can affect somewhat the absorption of the levodopa. However, it affects more the advanced patient, the advanced Parkinson's patients, more than at the beginning of the condition. However, if keeping or limiting the diet completely of protein is not recommended either. So it's a matter of when you're going to eat it, regarding to the time that you're going to take your medicine. And if this causes some problems because of side effects, because feeling nauseous, because you're not able to tolerate the levodopa by itself, I'd rather have the patient take it with the food, because the absorption, the problem with the absorption is not going to outweigh having you feeling not good and feeling nauseous the whole day. So it has to be individualized. But to answer the question, technically, yes, it can affect the absorption, but we have to put it in context with the whole picture.
Okay, all right. What's the difference between a DAT scan, EEG, and a CAT scan?
So a DAT scan, an EEG, and a PET.
It's a DAT scan, EEG, and CAT scan.
So EEG is a measure that we use to check the brain waves. So the way that it is done in a neurology office, and it uses leads that are glued to the skull. You're not going to go into any machine or anything of that sort. There is a preparation for that, and we use it for different situations. We do use it for seizures, but we also use it for altered mental status, for changes in cognition. We're looking for slower waves that may happen in the brain. And as a matter of fact, as we grow older and there is atrophy or brain aging, we're more prone, up to 20%, of having seizures. And not all the seizures are your typical ones that you will see the patient collapsing and shaking. Some of the seizures could be just staring or just doing some automatism, and we're not even sure. We think that is normal, that we're spacing out. And so we would be using the EEG in that setting based on the clinical history that we get from either the patient or the family. A CAT scan is an imaging study, so it's not done at the neurology. It is done at a radiology facility, and the CAT scan is basically a tube. It looks like a tube, right? And you go in there in our case, to check the brain. We do it more to check, to rule out bleeds, for example, or to rule out pathology that is big enough to be seen there, because when we need really the details, we prefer to go for the MRI. Now, the MRI, there are some contraindications. Some people cannot tolerate it because they are claustrophobic, but also if you have a pacer or any kind of implantable devices that cannot be in a magnetic field, then you cannot have the MRI. But those are in a different setting and for a different reason. And the DAT scan is nuclear medicine, so it's a different test as well. So a DAT scan measures the dopamine transporting in the brain, and this is a nuclear medicine test that we use we use it in the setting of somebody that we're trying to differentiate Parkinson's versus essential tremor, for example. So for 3 different indications and in 3 different settings.
Okay. For Gary, any advice for newly diagnosed to navigate emotional and physical changes?
That's a critical thing, to have a network to support you, family, friends. And the difficulty is, once you're diagnosed, it's hard to say, but some of your friends disappear. Mm-hmm. And it's a true thing. They don't know how to handle the disease. They don't know how to be around you. And you have to be able to navigate that while navigating your personal challenges. And so church, family, friends, build that network and live by humor. Find humor in everything you do and tell stories about it. And it just changes the game.
Okay, thank you. What are tips or issues with Parkinson's and dental hygiene?
So I'll tell you what I know. So we do know that there are some dental issues in people with Parkinson's disease, and some people even believe that carbidopa, levodopa can make people more prone to develop cavities. So it's very critical that you keep an eye with your dentist, make sure that you're going twice a year and get it checked and so on. And we do know that there's some bacteria that can accumulate in your teeth, and dental health is critical even for brain function, right? So we do believe that is a critical part. But in the Parkinson's disease world, we do some people believe, and I'm kind of jumping into that wagon as well, where these medicines can affect, can have an impact in your dental health, having more cavities, especially with carbidopa, levodopa.
That, and I would add also, remember that the drooling becomes a problem, right? And even though we treat it different, but having involved the dentist in all this is important as well. And going to the dentist appointment is another challenging, especially if you're shaking a lot or you have dyskinesias, etc. So it has to even be planned and taking your medications on time, etc. So when you go to the dentist, you're able to have the procedure or the dental cleaning that is going to be done.
Okay. Now, cannabis. I'm surprised we didn't have more questions about this. How does cannabis interact with PD meds?
You guys want to tackle that one? You guys want to tackle, or?
Anybody want to say something? Yeah.
So usually we can't get into too much commenting for or against the use of cannabis, just because the way the law is. We have heard some patients say that they've tried it and have had a good response, but there's a lot of studies out there that show there might be some benefits to use, but then we see a lot of studies that indicate that there could be side effects and adverse effects. So at this point, this is not a large enough body of research that is conclusive where we could comment one way or the other in general.
So, just the comment that I have in cannabis, let's go back a couple of years when this stuff was getting approved, right? And when cannabis was approved, everybody was jumping into the clinic like, I want that thing, right? And then a lot of people stopped taking their medication and they went for the cannabis doctor and they start having their CBD and whatever it is. And then everybody was coming back like, doctor, that stuff is not working. I think I did the wrong thing. I fell down 3 times before I decided to go back on my regular medicine. So in my experience, probably, the best use of cannabis in Parkinson's disease is to help people sleep. That is a really good way to get to sleep, right? That would be number one. And then number two, people that are very anxious, sometimes the cannabis can help, right? And so that can help with anxiety. And if you calm down the anxiety, the tremors get better. Let me tell you, and I always, some of you probably heard this already. Let me tell you the problem with cannabis medicine. So when you see your doctor to have cannabis medicine, your doctor will not give you a prescription. All that the doctor is going to do is say, yes, you do have a condition that, according to the Florida statutes, is approved for medical cannabis. That's it. But they're not going to give you, smoke this variety 3 times a day or every 2 hours for your Parkinson's disease. That will not happen. So once you get the approval and you get that card, you have to go to the dispensary, right? For those of you that have done this, tell me if I'm wrong. And then when you go to the dispensary, you meet Jimmy. Jimmy's a great guy. I love the guy. He works at Subway between 8 and 12 in the morning. And then from 1 to 6 p.m., he works at the dispensary, right? And there you go with your 12 years of Parkinson's disease and tell Jimmy, fix me up, brother. Give me the cure. Give me that stuff. And then, Jimmy's going to look around. Oh, my God, look at that one. I haven't sold that one in a while. So I'm going to tell you what you need. Bang. And sometimes, that stuff has a lot of THC and CBD and whatever it is that is there, right? And there might be a way to do this correctly. But I'm going to tell you what the truth is these days. So then my patients that are 84 years old, taking multiple medications, take this stuff, and suddenly they're dizzy, they're falling down, and some stuff is happening. So there might have been an opportunity there, and people, at that point they said, no, I didn't feel good with that, it didn't work out for me. It might have been the wrong way to do it. So I am sure, and I bet there are some guys around town that will know how to do this well. But I have to say that most of them, 9 out of 10, do not. And this is the reality of what happens with medicine, medicinal cannabis these days.
On the other hand, for other conditions, for example, epilepsy, there are FDA-approved medications that are based on cannabis. So we have to, again, take it, it depends, right? For Parkinson's, Dr. Rodriguez just explained, but yes, it does exist for neurological conditions, and epilepsy is one of them, and this is a capsule, and you need a prescription for this, so you would not go to everywhere. Like, you're not gonna meet Jean. You're gonna actually go to a pharmacy to get this, or it's gonna be shipped to you.
Obviously, you didn't grow up in the 70s, so. Let's see what I remember from that. Okay. All right. Is there a RSO, Rick Simpson Oil Protocol for those with Parkinson's? Never heard of that.
Never heard about it.
Never
I
heard of
cannot
that.
comment.
The person who wrote it, do you want to elaborate a little, or? No? Okay. Never heard of that. Something we can look into. Okay.
Don't throw it away, so we can look into
I'm
that.
not going to throw it away, no. What can I do to get more than 3 hours of sleep at night? Cramps in my legs and feet when lying down, toes curling up.
Yeah.
You want to tackle that
The
one?
THC, we discussed that.
Yeah,
The medical cannabis, right?
really. And you won't remember it in the morning.
No, so hold on. No, there might be stuff we can do. So we believe that when people are having a lot of cramping during the night when they're sleeping and even wakes them up, and then in the morning they have the toes, the big toe sticking up and the other one's facing down, right? And you wake up and you're walking on them. So what we do believe is that the dopamine levels have gone down a lot. The last dose might have been at 8 p.m. And then I told you a little bit earlier, we were talking about all these medicines, that the half-life of carbidopa, levodopa is about 90 minutes. So by midnight, that stuff is gone. So now you're going down, and you're hitting multiple thresholds about how low it is. And the body begins to react in different ways. And cramping is common. Toe curling is common. Happening at 4, 5, 6 in the morning is very common. So we believe that if we give a long-acting version of carbidopa, levodopa, we might be able to help that people. That is why these long-acting versions of carbidopa, levodopa, we believe are playing a critical role. That's where Rytary is, that's where Crexon is, that's where the pump that I showed you a little bit earlier is, and the new ones that are coming, and then these adjunct medicines that we're giving, what they're trying to do is extend the life of the medication during the night. For those that fail, they can have a Botox injection in the toes, or certain muscles, if they are easy to reach, to try to minimize the severity of this. And we do a lot of this.
Now, I would like to add that that's the answer to the question of curling, of toe curling. Parkinson's itself causes, one of the symptoms could be affecting the sleep. So sleep can be affected because of other issues that is not only toe curling, right? And it's important to be tested for that. So don't assume that is because of one reason. There could be vivid dreams, there could be urinary problems, there could be pain due to something else. They could even be visual hallucinations that can happen when you go to the bathroom. So other things can affect the sleep in Parkinson's, and that's very common, and that's going to worsen the symptoms next day in general, especially cognition. So you having that discussion with the doctor, and if it's not due to toe curling, the other reasons may need a different treatment. So, and you may need a sleep study. It could be sleep apnea. It could be something else. Like, not because you have Parkinson's, everything is Parkinson's, right?
I have a question, backing that up. That was my question. I am on a sleep app machine. Can't wear it if I can't go to sleep. So, and also I'm on the levodopa medicine. And if I take it after 3, it keeps me awake.
3 in the morning?
At night, yeah. No, in the afternoon. In the afternoon, I take it morning, lunch, and if I take it later than 2:30, 3 o'clock, I can't sleep. I'm wide-eyed and bushy-tailed all night long.
Yeah, so I'm just going to repeat what the question is for everybody to benefit. So in first place, she uses a CPAP machine, and that doesn't let her sleep. So you have to go back to the sleep medicine doctor just to look for any other options, right? And sometimes it's not possible, right? And I agree with you. Some people have side effects from the carbidopa, levodopa. And in that cases, we tried other versions of carbidopa, levodopa, maybe something longer acting or something like that. And if that doesn't work, you're doomed, in that case, right? No, it's not that bad, but it's just complex, right? We might need to use certain techniques to help you sleep. Maybe give you something to help you transition into sleep so you can sleep better. So at that point, it gets fancy. It gets a little bit more difficult. You need to work with your doctor about that. And you know what? Many times there's multiple attempts so we can get what the right medication is for you. Maybe you can take your 3 p.m. and then at night maybe take a little bit of something called temazepam. Dr. Dune was talking about that earlier, temazepam or Lunesta or something, just to try to get you to sleep so you can tolerate these kind of things. Set your brain, set the right stage for your brain just to, shut down and sleep some.
Severe symptoms in the legs with big knots of cramps and the curling.
Yeah, so she says she has severe symptoms of cramping in the legs and all that. Those things might have some treatment. Just talk to your doctor, okay? Ask him about something called nocturnal leg cramps, okay?
Okay. We're going to do one more question, and then we have to finish up, because I know you all want those door prizes. With all of the new drugs and treatments, how do you determine when it's time to move to the next stage of treatment? And are those signs or tests that indicate when it's time to move to the next? Are there signs or tests to indicate when it's time to move to the next level?
Okay. Hi, my name is Maria. I am the other nurse practitioner. I am the shy nurse practitioner here. Well, I have the answer for that question. When we have a patient and we have like a protocol, and we start with the medicines, and when we see the medicine is not working with the patient, we see the patient is in, for example, with Parkinson, we talk about time on and off. And when the patient is in a time off and the medicine is working for the time, we don't change the medicine because it's working, we don't need to change. But if we see the patient start to feel like he need to take the medicine earlier and he start to feel the symptoms of the Parkinson, we change to another medicine. If we see that medicine is not working, we go, step by step and try all these different medicine until we have the